Thank you so much for having me. I'm Karen Bernstein. I was actually born in Brazil, born and raised there, and moved to the United States to train. And I work at Mass General. I'm a radiation oncologist, and my expertise is in treating sarcomas. So I'll be sharing with you tonight how we do IGRT for lung and also extremities, and also the immobilization devices that we have been using. Thank you so much for having me, and this is a great honor for me to be meeting you and being able to be part of this team that is exchanging ideas with South America, and we'd love to continue doing this in the future. So just want to briefly go over the agenda that I would like to discuss tonight. So we're going to talk about lung SBRT for primary and metastatic tumors. I'm not a lung doctor, but I treat a lot of metastatic lesions with SBRT. We're going to talk about the CT simulation that we perform for these patients, the planning, immobilization devices, and IGRT. The next portion of the talk will be concentrated on the treatment of the extremity sarcomas, how we do the CT simulation, immobilization devices, and IGRT. So very briefly, just the management of stage 1 non-small cell lung cancer. A quarter of the patients present with early stage disease. And as we know, the surgery is the gold standard of treatment. For patients that are operable, it's usually lobectomy or pneumonectomy that is performed. And for the high risk operable, is usually wedge, segmentectomy, or VATS. 20 to 30% of the patients are medically inoperable and therefore need an alternative type of treatment. SBRT has been given for these patients very proficiently and actually with excellent outcomes. And we know that the high dose perfraction is much superior compared to conventional radiation. Another alternative is radiofrequency ablation, and we have a lot of folks that are very interested in doing this at Mass General. The interventional radiology team is growing very quickly here. And we know that if we don't do anything for this patient, greater than 85% with early stage disease will die within 5 years of their presentation. So this is just a depiction of the possible surgeries that can be performed. So from a very small wedge resection to lobectomy, segmentectomy, or even a pneumonectomy. So who are the people that can actually be operated on? It's very important to perform PFTs. The surgical mortality is less than 4% for lobectomy, less than 9% for a pneumonectomy. The minimum FUV1 for a pneumonectomy is greater than 2 liters, and the minimum FUV1 for a lobectomy is greater than 1.5 liters. And for people that have worse FUV1, usually wedge resection is considered. The surgical outcomes are not great. The overall survival at 5 years, 60 to 70%. Local regional failure rate with lobectomy is 6%, with wedge resection 17%. And there is really no better improvement of these results if you do intraoperative brachytherapy. When people have surgery, there is usually upstaging of the disease in approximately 25% of the cases. 9% with increased T-stage, 14% with increased nodal stage, and 2% are found to have metastatic disease. With conventional RT, as we know, reviewing several studies using doses that range from 45 to 66 gray in fractions of 1.8 to 2 gray per fraction, the outcomes are not very good. Local control rates of 30 to 50% and 5-year overall survivals of less than 40%. There are a few characteristics of patients that tend to do better with this type of schedule. So tumors that are small, patients that are younger than 70 years old, squamous cell carcinoma histology, or incidental diagnosis, so usually small lesions. Then came SBRT, and the initial US studies, the study that was conducted in Indiana by Dr. Timmerman, that looked at 37 patients with medically inoperable stage 1 disease. The tumors measure less or equal 7 centimeters. The study was to proceed with a dose escalation, starting at 8 gray times 3 fractions, and this was increased by 2 gray per fraction up to 20 gray per fraction in 3 fractions. So The schema was to have 3 patients per dose level. The primary endpoint was to find the maximum tolerated dose. If grade 3 or greater toxicity was reached in 2 out of 3 patients, that dose was considered dose limiting, and that's where they reached when they got to 20 gray. And initially, they didn't actually use fiducial markers. There was no cone beam CT, no heterogeneity correction. They treated any location in the lung, but they used abdominal compression since the beginning. And I think Dr. Zimmerman really likes this method to decrease the motion. So again, they reached a final dose level of 20 gray in 3 fractions. 1 patient, each at 14 and 16 gray dose levels, had grade 3 pulmonary toxicity. And at 15.2 months of median follow-up, there were no cases of greater than 3 late toxicity. The local control was actually great, 84%, with no failures happening at doses greater than 18 gray per fraction. Disease-free survival and overall survival, unfortunately, didn't really improve in comparison to the patients that have surgery. Then came RTOG-0236. Dr. Zimmerman, also the lead author. This was a phase 2 multicentric study where 59 patients were enrolled, 55 in the end were evaluable, and these were, again, medically inoperable T1, T3 lesions, N0, M0. The tumors had to be 2 cm away from the bronchial tree, and the prescription was 20 gray in 3 fractions, delivered over 1.5 to 2 weeks. The prescription isodose line was 80%, and they didn't have a heterogeneity correction. So with the density corrections, the actual dose of the PTV was approximately 18 gray per fraction to a total dose of 54 with the 3 fractions. And here they were using for DCT for planning, and if the tumor motion was greater than the PTV margins of 5 millimeters axial and 10 millimeters cranial caudal, they used abdominal compression, breath hold, or respiratory gating. And conformality and those constraints are also defined in this protocol. So in terms of results, primary tumor control was 97.6%. The local control at 3 years was 90.6%, and this was the involved lobe. The local regional control at 3 years was 87.2%, and disseminated failure at 3 years was 22.1%. Then they had the 5-year update of the study, and the primary tumor failure rate went up from 2.4 to 7%. The recurrence rate within the involved lobe went from 9.6 to 20%, and the local regional failure also went up from 12.8 to 38%. Overall survival went down to 40% at 5 years, and the median overall survival at 4 years was evaluated. Now moving on to what I actually do here, SBRT for metastatic disease. Unfortunately, this is a common scenario for patients that have high-grade sarcomas. So I actually conducted an analysis of the patients that were treated here at Mass General in collaboration with a colleague from UPenn, Dr. Baumann. So we had a total of 44 patients treated with pulmonary sarcoma metastasis. These 44 patients had a total of 56 separate lesions. They were treated here from 2011 to 2016. The median age was 59 years of age, and the treatment was a total dose of 50 gray delivered in 4 or 5 fractions. A lot of the patients actually had received prior chemotherapy, and many of them, 66%, had 1 to 5 prior pulmonary resections, and 32% had received prior radiation to the lung. So heavily treated population. The patients were followed every 3 months with CT or PET CTs. The local failure was defined as greater than 20% increase in the longest tumor dimension. And with a median follow-up of 16 months for all patients and 21 months for the patients that were alive at last follow-up, the local control was 96%, and at 24 months was 90%. So we were very happy with what we achieved. The overall survival at 12 months was 74%, and at 24 months was 46%. There were actually 3 failures. 2 lesions measuring 1.6 and 2 cm failed at 5 months after treatment, and 1 lesion that measured 3.9 cm recurred 20 months after SBRT. 2 of these 3 patients that had local failure received SBRT as salvage after failing metastatectomy at the same site. And in terms of toxicity, we found that there were just really very few patients with chest wall toxicity and 1 patient that developed pneumonitis. So why do we do SBRT? In general, really, greater dose leads to greater local control. And from the APM TG 101, it stated that this can maximize local control. Chemotherapy and traditional fractionations many times are not very effective against this high clonogenic density of these tumors. Also, the control of metastatic sites may prevent the evolution of the disease beyond the ability to control it. Also, there is advantage in reducing tumor burden below the fatal limit. There is also the opportunity of having immunomodulation with this high dose perfraction that can have these responses that seem to be quite prominent when we do high dose perfraction instead of regular fractionation. And also, it's great in many situations to palliate tumors. It's very important to follow the physics requirements when people are trying to introduce that to their clinics, and you're probably very familiar with this. It's important to have very good immobilization devices and good equipment to actually localize the lesions. And then there is also a need to have very good teams in dosimetry and physics to help us provide the patients with very good and high quality treatment. So here we follow for physics requirements what is published from the ACR and ASTRO, also the APM recommendations, and also the past RTOG experiences. So very briefly, just highlighting the recommendations from ACR, ASTRO, it's important to have acceptance testing and commissioning. It's very important to have quality control of the program for the SBRT, and it's extremely important to have very good treatment planning processes in place. From the APM TG 101, it's also required that a physicist be present for the beginning to the end of the first treatment, and they should be available for the following treatments if there is any difficulty with the delivery. And it's also recommended that a radiation oncologist approve the results of the image guidance and verify the port films before every fraction of the SBRT treatment. Other recommendations is that one should perform an end-to-end test using phantoms, because there are multiple errors that can be introduced in the technical delivery of the SBRT. So in terms of immobilization systems, this is extremely important when we are delivering high risk, high dose to normal tissues that are in the vicinity. So this really requires an extra effort to be able to localize these lesions very precisely, and immobilization again is extremely important. So using a combination of immobilization and frequent imaging assures one that the delivery is being precise and accurate. It's very important to have a patient that will be able to lie for a long session. Many times, as you know, these treatments can take 1 hour or more. And the typical desired uncertainty level here is plus minus 5 millimeters. It shouldn't be greater than that. This is just a depiction of immobilization systems where you can have many areas that are movable and really indexable for foot positioner, leg and knees, respiratory plate, indexable arms, upper back, head immobilization. I mean, this is probably something similar to what you have in your clinic. We use something that looks like this here in Mass General. And in terms of the body fix, we use this large vat bag that immobilizes the patient for the treatments. Usually we have a wing board in place. We don't usually use a cover sheet. I don't know what you have been using in your clinic. In terms of tattoos, usually we place 4 tattoos in these patients. We usually conduct a 4D CT. Abdominal compression hasn't been done in the past 2 years here at Mass General. I think they thought it was too traumatic, so they have been trying to avoid using the compression, but gating is used very frequently. And the treatments are usually LINAC-based, VSIM, and we have Conbeam CT on board in the machines, and the couches do translational corrections if needed. And this is the immobilization system that is used. The simulation is done with a helical scan. Usually approximately 300 images are acquired. And for the 4D CTs, as you're familiar, many more images are acquired, around 3,000 images. The table moves with every breathing cycle. We watch the breathing, make sure that the breathing is regular, to make sure that this patient is a good candidate to have this type of treatment. In terms of motion management, the internal motion, respiratory, or any other motion, for example, the heart motion as well, may lead to increased toxicity of organs at risk and possible decrease of local control due to a geographic miss. The ways of assessing motion can be via 4D CT, fluoroscopy, and a breath hold can also be used. This is just a depiction of a 4D CTs, so monitoring the respiratory phase during the CT scan. Multiple CT sets are reconstructed by associating these images at similar respiratory phases. For lung treatment planning, the target is usually contouring the 50% breathing cycle. This volume is displayed within all the breathing cycles to create an ITV. The organs at risk are usually contouring the average IP. For PTV margins, we usually use plus minus 5 millimeters. And this takes into account the proximity, to chest, bronchus, or vessels. Sometimes, if it's very close to those structures, one uses a smaller PTV. And the planning, again, is done on the average IP. If you use 3D conformal, when there is large motion and you want to avoid gating the situations, it requires at least a 3 cm minimum field size, and the prescription is usually delivered to the 80 or 90 isodose line. If one is using VMAT, we are using here the 6 MV free flattening filter, and the prescription is up to 100% level. And when using IMRT, we usually use 7 to 8 fields. The conformity index should be as low as possible, so less than 1.2 is what is usually recommended. For target definition in the presence of motion, we use the ITV to construct the volume encompassing the complete range of the motion. And gating can also be performed. Usually we use the phases 40, 50, and 60. This is just a depiction of the IGRT, SBRT delivery system, the variant trilogy. For localization of the lesions, one can have MV portal imaging, KV radiographic imaging or fluoroscopy, Conbeam CT, diagnostic CT or CT on rails, MR LINAC or PET on gantry. We do not have a MR LINAC here or PET on gantry. And this is just depicting the IGRT and SBRT delivery systems.
Dr. Bernstein?
Yes.
I have a question. Could
Yes.
you go back a few slides?
Mm-hmm.
To where you had the 1.2 as the normal limit that you use for conformity index. Doctor Saria, yo quería ver si en Perú usan esas mismas estándares. Está mudo. Ok, ya.
Aló, ¿ven?
Hola.
¿Qué tal? ¿Cómo estás?
Bien, ¿qué tal?
Pues sí, nos referimos al ICRU. para tener el criterio de aprobación, al menos en A1.
Ok,
Okay.
perfecto, como hacemos nosotros.
Y
Correcto.
el siguiente slide que dice 40, 50 o 60%.
No
También
tengo
usa
visión.
the gating.
Ah, sí, Kelly. El FC Windows. Sí, correcto. Eso lo usamos. Aquí. Sí.
Okay. Y en su experiencia, doctor Saria, no sé si has visitado otras clínicas también. Todos ya tienen esos datos, todos bien y todos usan lo mismo. ¿O?
No, no está estandarizado. Apenas serían 2 centros más que están empezando. Bueno, uno tiene ya 3 años con experiencia y en INEN están recién empezando menos de 6 meses,
Menos de
pero
6.
no hemos podido todavía estandarizar y más centros todavía recién van a implementar estos criterios, ¿no?
Ajá. ¿Y piensas que una sesión como eso sería algo útil para esos centros que recién están empezando?
Sería buenísimo poder estandarizar desde el inicio para que el trabajo sea homogéneo.
Ajá. Ok, pues después hablamos de los siguientes pasos. Listo, gracias.
Correcto.
Thank you, sorry.
No problem, thank you. And please feel free to interrupt if you have questions. Here is just really talking about the imaging that can be performed. So as we know, if you do radiographic image, this can be used for rigid translation, for target mobilization, and this is really good to have bony anatomy alignment, or when a patient has implanted fiducials. The combined CT, on the other hand, gives you volumetric imaging and allows for complete translation and rotational alignment assessments during treatment. And it's also much better to visualize the organs at risk in relationship to the target. These are the 2 treatment approaches. So the non-gated having a much larger envelope and the gated with a smaller envelope. And here just depicting the localization. Usually we are called to the machine when they are in the process of doing this. And then, once we are happy, that's when we proceed. And this process can take a little while until we get to the perfect alignment. So this is a case that I treated of a gentleman with a grade 2 leiomyosarcoma in the right lower extremity. He received radiation and was treated surgically, and unfortunately, a few months later, developed metastatic disease to the lungs. The initial treatment was a wedge resection, and this is something that they do quite frequently if the patient is operable, but also it's a way to have the diagnosis to confirm that this is indeed metastatic disease and to resect the lesion at the same time. But many times after one is resected, if the person has more, we are treating a lot of those folks. So here I actually treated 2 new lesions with 50 gray in 5 fractions. And these were the lesions that were treated. Again, 50 gray in 5 fractions. And the local control rate, I spoke about the local control that we achieved here, and UPenn and Mass General, actually, we didn't have any failures. So it's pretty effective for this high-grade sarcoma patients. Now I want to speak about extremity sarcomas. This is really my expertise. And IGRT has played a major role in decreasing the target volume that we treat in these patients. This is RTOG 0630, and image guidance was applied in 57 patients with soft tissue sarcomas that were treated preoperatively, and the results were really fantastic in terms of long-term side effects. So the CTV that was used for grade 2, 3 lesions that were on the large size, greater or equal 8 centimeters, was a GTV plus 1.5 cm radial margins, plus 3 cm margins sup to inf. And if the tumors were smaller or lower grade, the CTV was much smaller. So it was just the gross tumor volume with a 1 cm radial margin plus 2 cm sup inf And in the CTV, all the T2 MRI changes were included, but there was no expansion on the T2 MRI changes that were seen for these sarcoma patients. And the PTV was the clinical tumor volume plus 5 millimeters for setup error. The primary endpoint was really to find if these patients that were treated with smaller field sizes, if they would have less grade 2 toxicity in the future. For daily pre-radiation image, for this particular study, they accepted different ways of doing this IGRT. So you could do 3D with cone beam CT. You could also do 2D with KV or MV. And the bony landmarks were used for alignment, not the soft tissue. The dose that was given preoperatively was 50 gray in 25 fractions. Most of the patients were treated with IMRT, 74%, and 16 gray boost was delivered for patients with positive margins. And this was actually a minority of the patients, only 16% of the patients required this boost. The acute wound healing complication rate, unfortunately, didn't decrease, even though they used smaller size fields. It was still 36.6%, but the late-term toxicity actually went down, was 11%, and this actually was much better compared to what they had achieved in the NCI study that was conducted in Canada, where the long-term toxicity in terms of fibrosis, joint stiffness, edema was around 37%. So in summary, IGRT with reduced target volumes led to significant reduction of the late radiation morbidity compared to NCIC CTG trial with preoperative radiation. There were no marginal field local failures, which was a concern in the beginning. Using smaller fields, if one would have more local failures. The limitations of the studies that when this was published was really preliminary data with a very limited follow-up. Then they had a secondary analysis just looking at the impact of daily IGRT on the CTV to PTV margin. They looked at 98 patients from 18 different institutions. Everybody had IGRT, and the recommendation in the end is that the expansion from CTV to PTV margin was 1.5 cm if there was no IGRT, and one could really reduce it to 0.5 cm if daily IGRT was used. When we do the simulation for these patients, we first of all make an immobilization device, and we always use IV contrast to delineate the target. And these are just a few immobilization devices that are constructed for these extremity sarcomas. And it can be challenging, but we have great help here to create these immobilization devices. And I actually have a short movie just showing how this is done. And again, cone beam CT it's done daily to position these patients. And this is just a few examples of patients that were treated with IGRT and Mass General. So this is a 81-year-old woman with a grade 3 stage 2 spindle cell sarcoma in the right posterior thigh. She got 50 gray preoperatively, and this is the mobilization device that was performed to hold the leg in place. And this is the depiction of the VMAT plan. The second case is a young gentleman with a T3 and 0M0 grade 3 spindle cell sarcoma of the right thigh, also received 50 gray and required a boost with another 10 gray. This was the mobilization device created for him. We try to really separate the legs the best we can to avoid treating the contralateral leg when we deliver the treatment. And this is the depiction of the VMAT plan. And the last case, an 85-year-old gentleman with EPS in the left upper extremity. This was the mobilization device. And this is a depiction of the lesion. Here, really mobilizing different areas of the limb to prevent rotation and of course, deflection or extension. And this is another picture of the mobilization device. We make these gloves, and this pillow actually is made of a material that doesn't build up those. and it shapes to the hand of the patient very nicely. And this is just a depiction of his plan. And this is not the case with a gentleman with a high-grade UPS in the left back that received VMAT. So in conclusion, IGRT plays a very important role to deliver radiation safely. It allows superior tumor control, and really having the best possible mobilization is extremely important. Precise tumor localization is extremely important. And the patient has to be really able to comply with the treatment, because some of these treatments are quite long and require a patient to be comfortable and just have an understanding that, you know, this is indeed a long treatment and we cannot have motion during the treatment, which can be quite difficult in some situations. So I want to show you how we actually make these devices here at Mass General. This is the video of Ed. He helps us with this construction.
We make custom Sarcoma boards. It's all very basic. We make it with very simple hand tools, multi-birch plywood, and we cut the plywood just a little bit wider than the table, so we can actually have mounting holes that will, we can drill holes that will mount to the same place for the CT couch and for the treatment couch. The basic tools we use for that is a drywall square. We have the placement of the holes, transfer the holes. If you have more than one combination of sizes, you can use different size holes in different places. That we use quarter 20. All of the hardware we use is quarter 20, so it's one standard size. Quarter-inch drill, all the bolts the same, all the nuts the same. So it works out to be very efficient that way. We use that same system to mount the base foot plates. The foot plates we utilize after we use the plywood for a patient. And if we cannot no longer use it for a patient, we'll actually cut it up and make the basic foot pieces. It's just the same plywood. Cut it with a basic saw. We'll use a block with quarter 20 bolts on it. Run it across, and that gives us basic foot plate. You can make it any size you need, any shape you need, and you utilize it. You can utilize it for different patients. Basic hand drill, quarter-inch drill. Basic holes. We use a quarter 20 countersink. With the countersink, that will allow us to use hardware that will sit flush against the board. And here's the finished board. We'll use a countersink underneath the foot plates. This allows you to use several widths. We'll take the same foot plate, move it in, so it's adjustable. It can go in the first set of holes or the second set of holes. You can pre-make these before the patient comes in, so it's all set when the patient comes in. If you don't have a space like this, you can do it, whip down it on the CT couch at lunchtime. It's all pre-made. Slide it in with the bolts that are there. Wing nuts. And you're ready to go. If you need to frog leg a patient, we've made basic flat piece with a small bracket on it. We can place the leg in whatever position you need and use just small counter screws on that. Here's the board is mounted. If you're treating the area that you're treating in, you want to put how it mounts to the couch outside of the treatment area. You can get artifacts from the hardware. So You'll keep that clean, so we'll use 2 sets of holes, depending whether it's a thigh or a calf. These again are adjustable. It's all very basic. We built it with basic hand tools. It takes about a half an hour to build it, and we'll use pre-cut aquaplast pieces, and we can use those as a foot mold. We'll mold those around the foot. We'll use aquafoam cushions underneath the legs, so you have 2 points of immobilization. That doesn't, we'll use a piece of styrofoam underneath it to make it fit the patient's anatomy, and attach that with strap.
All right, so I hope that this was helpful. This is Ed, he's fabulous. His background is in carpentry and worked with the orthopedic surgeons for several years and has been with us for almost 20. So that's how we mobilize these extremity sarcomas. And it's extremely helpful, and it's actually quite simple to make these boards. And again, the one thing that he highlighted is to have the screws away from the area that you're treating, and that's extremely important. Otherwise, it creates a lot of artifacts. So that's the only thing that you have to be careful about when you're making these boards.